Hi, this is Dr. Bob Dannenhoffer. I'm a public health officer in Douglas County here in Oregon, and I'm doing another of our Facebook Lives. I'm here in the studio all by myself, so I'm going to take down the mask here so that we can actually read lips. I'm always impressed at how many people read lips. So again, Dr. Bob Dannenhoffer, public health officer in Douglas County. It's December 11th, and this is now another of our Facebook Live. This is a chance for you to ask questions. I'll try to do as best I can to answer those questions. I may not get it all right, but I will try as best I can. So please either put them in the chat section, or if you want to send them to us in between our tapings, you can do that at Facebook questions at douglaspublichealthnetwork.org. Again, Facebook questions at douglaspublichealthnetwork.org. Very long, but we'll get those questions and answer them for you. So as always, we start off with the world view and then move down to the local view to see how things are going. And this still is a very active pandemic. We're now at 71 million cases in the world and 1.6 million deaths. We are adding cases as a world at record paces and adding deaths at record paces. This disease is still very active in the US, in Brazil, in India, Germany, Russia, the UK, and Italy. Disease is still going up in Brazil, Turkey, Russia, and clearly the United States, and it's pretty flat in India, Germany, UK, and Italy. To give you an idea of the relative amount of disease in those countries, the U.S., with 330 million people, has as much disease as Brazil, India, Turkey, Germany, Russia, UK, and Italy, with over 2 billion people in those areas there. So we have a lot of disease in the U.S., and a lot of deaths in the U.S. In the U.S., we're at 16 million cases. We will hit 300,000 deaths today or tomorrow. We've been averaging 200,000 cases a day and averaging about 2,300 deaths. 2 days this week, we've had over 3,000 deaths in a single day. I can remember so vividly 9/11, where we had 3,100 deaths in that day, and now twice this week we've exceeded that level. This really is just a stunning number of deaths coming really from all over the country. And indeed, this is a very active disease, except in a couple places. Maine, Vermont, Hawaii, and Oregon are the 4 places in the country, when you look at the heat map, that shows increasing levels of red with more disease. There are some places that are almost black, and they're so hot. And then you get to Oregon, and Southern Oregon is sort of a lightish yellow color. So we're doing okay, although I will tell you, for us, it still feels like a lot of cases. I cannot imagine what it must be like in those cases. So we're averaging now 10 or 20 cases a day, which is tough. For a population of 110,000. These places are averaging over 100 cases a day for a population of 100,000. I'm not sure how you deal with that. The things in the U.S. are really concerning is the ever-increasing number of hospitalizations. So we're now today over 100,000 hospitalizations for several days and continuing to climb. And at some point, the hospitalizations will climb, and we'll get to a point where hospitals will get overloaded. And so far in Oregon, we're not there yet, but in other places we are. You see pictures of people putting beds in parking garages or at convention centers. That is very, very worrisome, because you can build new beds and you can put sheets on them and whatever, but the thing that you really need are trained people to take care of sick people, and those people are very, very hard to increase. I was watching a story yesterday where they were saying at this place, nurses working 12-hour shifts, 12 days in a row, a weekend, 12 more 12-hour shifts. Human beings are not made to work that many hours, especially in the high-tech, stressful world. And so I'm very, very worried about those hospitals and especially about their staffing. In Oregon, we're at 89,000 cases, a little over 1,100 deaths. I think our cases in Oregon peaked in the week before Thanksgiving. So you remember 2 weeks before Thanksgiving, the governor reinstituted the freeze in Oregon. We said if that was going to work, we'd start to see the results in 10 to 15 days, and then it takes a few days to see if that's for real. And it really does seem to be for real. It really does seem that Oregon peaked in that week before Thanksgiving and has been down since. But the chronology of cases is gatherings lead to cases, Cases lead to hospitalizations, and hospitalizations lead to death. So the cases in Oregon seem to be peaked the week before November. Hospitalizations seem to peak early this week, but we're still having lots of deaths. So we're averaging now 21 deaths a day. So when we look at this, Oregon, though, is, as much as this sounds terrible and is terrible to me, we are still the 5th lowest state in the country. So if you look at the number of cases per million or the number of deaths per million, we're the 5th lowest state. And then if you look at, in the last 2 weeks, where we fit, we're the 4th lowest state. So as low as this seems like a lot to us, it's not a lot to others. And I'll talk a little bit later about the conundrum of low cases. In Douglas County, we had just 11 new cases today, which is one of our lowest case counts in a while. We have 14 hospitalizations, which is down from the peak. It was 21 before. We had 2 new deaths today, and I expect we'll have more deaths over the weekend. Again, we seem to peak in that week before Thanksgiving. Our hospitalizations peaked last week, but I expect to see more deaths this week as people who have been in the hospital for a while just can't make it, or they decide to go home with comfort care. A couple of the good news is we did not see a huge rise after Thanksgiving. We were very frightened that there were going to be a lot of gatherings, We have a bunch, but not nearly as many as we'd worried about. And so that's a good thing. We're still seeing big outbreaks at Forest Glen, Curry Manor, a couple of church outbreaks. The outbreak that we'd had in Reedsport over Halloween has seemed to die down, and that's a good thing. So before October, we had no super spreader events. We had 5 in October. So far in December, 11 days into it, we've had no super spreader events, and that's what we're hoping for. So again, I think Douglas County is doing a good job, which gives us the conundrum here. If you had a lot of disease, people would say, well, we've got a lot of disease, what can we do? When you have a little disease, people say, well, you're overdoing it. You're doing too much, you're closing too much down, you're being too strict. But the problem is, the reality is, the reason you have fewer cases is because you have been strict. And so it's a little hard to explain why you need to have a lot of strict restrictions when your cases are low. But really, it's the obverse. It means the cases are low because you have the restrictions. So that is hard to explain. I think if we were in an area where there were a tremendous number of cases, people might understand that a little bit better. But certainly, I'm not suggesting we increase the number of cases so people recognize how bad it can be. A lot of great things to talk about today, and we'll get to them. But let me go through the questions. So Lee says, news media is telling us that we'll soon have enough vaccine to inoculate millions of Americans by the end of March. Are those estimates based only on the Pfizer vaccine with 3 other vaccines and maybe more and waiting approval? Does this mean we'll have enough vaccine to reach the 70% immunity threshold even sooner? So let's start with vaccines. So what we do know about vaccines is the Pfizer vaccine data came out this week. It looked great. It looked like it was really quite effective, and for Shelley, frickin' safe, because it really looked very safe. Really no long-term side effects, a little bit of lymph gland swelling, maybe a few people had Bell's palsy, but generally really quite safe, and very effective. So even after the first dose, about 50% effective, and 7 days after the second dose, over 90% effective. It looks like the U.S. will get between 50 and 100 million doses of the Pfizer vaccine. That's great. The vaccine requires 2 doses, so that means 25 to 50 million people can get vaccinated with that. The Moderna vaccine is coming out, is going to be reviewed next week. The preliminary stuff that I've seen suggests it's much like the Pfizer vaccine, and I think that will also likely get approved, and that will give us more doses, probably enough to vaccinate another 100 million people. Now remember, 330 million people in the United States. To get to herd immunity, we're probably going to need 250 million people vaccinated. 250 people times 2 doses is 500 million doses. So we are going to need the 50 to 100 million doses we get from Pfizer, the couple 100 million doses we get from Moderna, and then we're going to need some of the other vaccines. And there are a couple of other vaccines out there. So AstraZeneca has a vaccine. Johnson & Johnson has a vaccine. There's a company called Novavax that have a vaccine, but their vaccines are a bit longer off. So even in the best of things, I don't see those vaccines getting approved to January or March. So I think what's going to happen is we'll get a big bolus of vaccines. Pfizer's going to really deliver all the vaccines in the first month. So we'll get a big bolus of vaccines in December. We'll get more with Moderna in January. But I think we'll come to a point in January where we have more people wanting the vaccine than we have vaccine. The question is, when will we hit that 70% immunity threshold? I don't know. My goal is to hit it by the 4th of July. Wouldn't it be great to hit that by the 4th of July? We go a few days, say, hey, we haven't had any new cases this week. And we truly celebrate the idea that we've gotten this behind us. As people know, I'm a little impatient, and so that may be more aggressive. I think certainly people think by the end of 2021 we'll get it, but I don't want to go through another fall like we went through this year. So Carol says, have there been any discussions at the county, state, or federal level about using other healthcare providers, such as dental hygienists, to give vaccines when they become available in Oregon? And yes, that's all been talked about, is extending the people who can give vaccines. It turns out I do not think that the people actually squeezing the vaccines in the arm is going to be the limiting factor. The limiting factor is going to be all of the other stuff that goes into it. So, for the last 5 years, we've been doing these drive-through flu clinics, and we typically have a bunch of nursing students give the vaccines. That is the shortest part of the entire deal. You have to get people lined up, driving, all in order. There's a bunch of paperwork you have to get beforehand before they can get it done. You then have to be sure that they don't have any contraindications to the vaccine. Then they drive out, get the vaccine, which only takes a minute or two. But then there's a bunch of paperwork that needs to be followed, and those people need to wait for 15 minutes so after they get the vaccine to see if they're going to have a reaction. So it turns out that giving the shot is kind of the easiest, quickest part. It's all the parts before it and after it. But I think we are very well set up to do this. This vaccine to give is only slightly different from giving a flu vaccine. We're really good at that. So I think we're going to be in really good shape. So someone says, are all of the deaths tied to the Curry Manor outbreak? No, some are, but certainly not all of them. There are deaths tied to each one of our large outbreaks, including the outbreak in Reedsport, a church outbreak here in Roseburg, Curry Manor, and Forest Glen. So the deaths are all around and associated with really all of those different outbreaks. So Tom says, what are the testing options for someone who's not symptomatic but would like to get tested before visiting with older family members? So a testing strategy to do a risky behavior is absolutely not recommended. So, this deal, I get tested before I fly, I get tested before I go to the White House Rose Garden ceremony, has been shown to be quite ineffective and associated with many super spreader events because the tests come positive really too late usually to figure it out. So there is a graphic that Vanessa, one of our people, made, and here it's had 11 million hits on the internet. So, it looks like almost everybody else in the world has seen it. So if you just type in Jane at Thanksgiving, they'll tell you. And so we did this little graphic that apparently a lot of other people liked, which was on Sunday, Jane gets exposed to COVID. On Tuesday, Jane decides that she wants to get a test before she visits her elderly relatives, and that test is negative. It will always be negative 2 days after you get exposed because it doesn't turn positive until at least the third or fourth day. So she gets tested. So she gets exposed on Sunday. On Tuesday, she decides she's going to do the safe thing and gets tested. The test is negative. On Thursday, when she is now infectious, she now sees her family. She is not symptomatic yet, but she is at her most infectious stage, spreads it to everybody at Thanksgiving. The next day, she starts to have a little bit of symptoms, and on the next Saturday, 6 days after exposure, she decides, I'm really feeling crappy, I'm going to get tested, and she gets tested and she's positive. She now took all those people that she saw at Thanksgiving that I was probably infectious during the time, and that's exactly how we see super spreader events go. So a testing-only strategy is not at all recommended. And in fact, in my book, one of the least safe ways to do it. So if you want to visit older relatives, and certainly many of us do, you should do what my sister did before she was going to go visit my mom, who I hope is watching tonight. So she wanted to visit my mom, and she said, Bob, what is the safest way for me to do that? Because I certainly don't want to bring it home to mom. So the idea is you need to quarantine for 2 weeks before you see mom, and that's what I would recommend. What about getting tested? Not really that important. Really the most important is the quarantine time. So if you wanted to be really, really safe, what you would do is you would quarantine, and then you would get tested somewhere during the quarantine, and then continue to quarantine until you visit the older family members. There is no testing strategy, including getting tested on the day you visited them, that is any assurance that you're not having the disease. So I don't really like the testing strategy. I really prefer the quarantine strategy. The quarantine strategy, we think, is 100% effective. The testing strategy, even if done with really high quality tests, has a 40% fail rate. That is way too high for me. So what I recommend is quarantine. So Christy says, I'd like to go to the dentist. Is it safe? Well, in the whole scheme of things, from really unsafe, like going to a concert, and really safe, like staying home and watching movies on the couch, this is pretty safe. It's not, dentists do an incredibly good job with protective equipment. They do a great job with masks. They are probably the cleanest place you'll go. And so we think dentists are fine. We have not had a single case in Oregon that's been tied to a dental procedure. Now, there have been some outbreaks associated with dental offices, like all offices. What happens is, you do your work at the end of the work, everybody says, that was a tough day. They take their masks off, share the cookies at the break room, and give it to each other there. So that can happen, but in general, dentist offices are really quite safe. So Ginger says, do hospitals have the refrigerators they need for vaccines? So the first vaccine that got approved is the Pfizer vaccine. That requires ultra cold storage. So ultra cold storage is really cold, 70 degrees below zero, like what dry ice is. So it's really, really, really cold. And I talked to Dr. Gray today, and they're getting their very low temperature freezer delivered now. Now the Moderna vaccine that's going to come out later does not have that ultra cold storage. And so I think we have plenty of the super cold freezers. So Lynette says, will substitute teachers be included with full-time teachers when essential workers are given the vaccine? I believe so, yes. Now the deal on who gets the vaccine in that 1B group, which are the essential workers, has not been fully decided yet. But really anybody who's got a part of an essential job should get vaccinated in that group. The problem is going to be that I think to get enough vaccine for that group, which is a big group. So the first group are people in nursing homes and hospital workers, probably in Douglas County, 10,000 people. The second group, though, are people in essential industries, probably 30,000 people. And so we're going to need a lot more vaccine for the second group than we need for the first. So I do have recommendations for safe lab draws for older people. Again, we think lab draws are relatively safe. Typically, people are using full PPE. You should have your mask on. And typically, those are short encounters. Unless you're a very, very hard blood draw, most of those phlebotomists are great, and they can get your blood in just a minute or two. And again, limiting the amount of time of exposure, wearing good protective equipment is the way to go. So Laura asks, is there going to be enough vaccine for the second dose? Yes, what they're doing is when they're giving places the first dose, they're holding back the second dose. So, for example, if Mercy's going to get 10,000 doses, they'll hold back 5,000 of those doses so that people can get the second vaccine. How are our doppelganger counties doing, particularly Valdosta? Really, really bad. So for those who haven't watched before, there was a discussion earlier this year about, well, we know the Douglas County experience. What's the experience around the country? So to look at that experience, I found 3 counties in other states that were a lot like Douglas County. about 100,000 in size, on an interstate, sort of a combination of rural and manufacturing, not anything weird like part of a Disneyland or something. And so I found 4 counties that we've been comparing all along. So we started doing this in August. At that time, we had much less disease and far fewer deaths than these other areas. So the other areas are Twin Falls, Idaho. Twin Falls, Idaho has really been racked. They're averaging 60 to 100 cases per day. We've never had more than 30, 60 to 100 a day every day, and about 5 times as many deaths. Valdosta is also doing badly, having a lot of cases and a lot of deaths. Actually, Georgia this week is really heated up. So I'm looking at South Georgia is really heating up. If you want to follow them yourself, if you go on the New York Times county map, you can by counties look at these numbers. But in general, we have 5 times less disease and 5 times less deaths than these other areas. So, that Douglas County and Oregon has been a little bit more cautious than the rest of the country, and especially than those 3 states, I believe has really paid off. So Joanne says, my husband is being tested in Grants Pass. Will you get the results? So we get the results from people that we do the test for, or for people who have an address in Douglas County. So if they get a test in Grants Pass and have a Grants Pass address, we're not going to get it. But if they get tested in Grants Pass and have a Douglas County address, we will get that. So Karen says, would you please speak to the female infertility from the vaccine? I looked at this. There's this website out there that says that the spike protein on the coronavirus is a lot like a protein which is on the placenta, and if we give the vaccine for the spike protein, it's going to kill off the placenta and make women infertile. And then it says it's also going to make men infertile because it's also on the sperm. I can find absolutely nothing other than that one weird website that suggests that. I looked at the proteins, I looked at the description of the proteins. They're nothing alike. So other than they kind of sound a little bit alike. So it's like, I think it's syntectin 1 and spike protein 1, and they just said they must be the same thing. They're nothing like each other. And so I don't get that female infertility thing. I've looked to see if there's anything behind this. It doesn't appear to be. It does quote the guy from Pfizer, and it says, and he filed an injunction with the European Union, and look that up. Well, I looked it up. It has nothing to do with female infertility. It has to do with a very, very technical psychothreshold issue on the Pfizer vaccine. So if anybody can find me more about this female infertility stuff, I'd love to see it. But right now it looks like it's just one of those internet things that we see. And we're going to talk a little bit more about internet things that you see that just seem to be spreading information to worry people. So Charity says, could you please explain why gyms are included in the shutdown so people understand its necessity? So it turns out that not in Douglas County, but in other places in the state and in many places around the world, gyms have been the sources of big outbreaks. And they've been the source of relatively big outbreaks because people tend to be close enough together. They tend to be breathing hard, which seems really to be an issue. And they tend to be around each other for a longer period of time. So you remember giving the disease to somebody else is related to how close you are together, how long you are together, and how much kind of air you exchange. So in a gym, you could be pretty close for a long time, exchanging a lot of air, so it does seem to be a big risk. And there are a number of really big outbreaks associated with gyms, and because of that, the decision was made to close down the gyms. Now that's really hard. Before all this started, I would go to the gym almost every day and have rarely been back. And so this is really hard for people who are getting out of shape, and really hard for people who have really a family that develops at the gym. So this is problematic. I am really, really hoping that our numbers are going to go down. And as our numbers go down, we can open up gyms again. So is it going to be mandatory for people to get the vaccine? Heather asks, no. I cannot imagine anywhere in the United States that this would be mandatory. I mean, we don't even mandate. We do mandate things for school. but that's because these are diseases that spread at school and diseases for which you need a very high level of immunity. Not the story here. There's not even any vaccines approved yet for kids, so I don't think it's going to become mandatory. These are not yet fully licensed vaccines. They are being approved under an emergency use authorization, so I do not see these becoming mandatory. So how is it possible that people are doing a drive-through testing at lunch and going back to work? Is it important to quarantine if you're being tested? Yeah, I'm not sure about that. If you're being tested because you're symptomatic, you certainly shouldn't be at work. If you are being tested because you need to have a negative test before you travel or whatever, also not smart, because if you get tested negative on a Tuesday and then go back to work on a Wednesday and get exposed, then when you go to Hawaii on Thursday or Friday, you could spread it to people there. So we're generally saying if you're being tested for any one of those reasons, you should also be quarantining. So Heather says, has the flu come yet? Very little flu this year. I follow the flu bites every week. Very, very, very little flu. Less than 100 cases less than 100 viral samples in the country. So very, 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 very low numbers of flu so far. We hope it stays that way, but I don't know. Usually flu doesn't peak in Oregon until January, February. What's the difference between closed tents set up for outside dining rather than dining inside, Janet asks. Well, outside dining, if you're going to have tents, it's supposed to have 3 open sides. I've seen some of these outdoor eating bubbles that are hermetically sealed. That is really no different from indoors. Really what we're talking about is the amount of airflow. And one of the ways you can see that is if you have a candle and the candle flows up nicely, there's not that much airflow. If you can't light a candle because there's so much air around, then there's much more airflow. And the reason about eating outside is that there would be more airflow. Now, if you get me in a perfectly sealed tent, there's not as much airflow, and that would be less of an issue. But I can tell you, people are trying to game all of this, so there's a lot of that stuff going on. So Crystal says, why is it so hard to get a free test? I have to get one to go back to work, and I don't have insurance. There is no place in the entire country where you need a test to go back to work. I spend every day, I'm calling employers to say, I called one yesterday, and they said, the guy said, I need 2 negative tests to come back to work. I said, that's not right. So I called their HR, and I said, where'd you get that from? They said, that's what we heard back in March. And back in March, that was the advice, but clearly not the advice now. So Crystal, if you can tell us where it is, we'll get you back to work without getting a test. So Stephen says, how are the vaccine made? I imagine 2 witches stirring a bubbling cauldron. Actually, it's 3. I don't know. Actually, the vaccines are incredibly complicated. So the vaccines are, so what happened is back early on, the Chinese published what the genetic code for this virus was. Other people replicated that, so we know exactly what the viral code is. And the viral code is a bunch of nucleosides that are together in a stretch, and we've used that now to see where there are mutations along the way. They found on that where the spike protein was. They then took snippets of that to find which part of that made the best antibodies. So they were able to find a stretch of mRNA, which is messenger RNA, that coded for the protein, and that protein, when injected in people or when injected in animals, made good antibodies. And so they found that mRNA, and then they reproduced that mRNA in these huge vats. They're not witches stirring it, but these huge vats where they made it. Then what they do is they take these little bits of mRNA and they coat it in a nanoparticle. So have you ever had the Dippin' Dots ice cream, which are those little round balls that are really cold and lipidy on the outside? That's kind of what these things look like. They get injected into the system. When they get injected into the system, those little fat globules with the mRNA in the middle go through the bloodstream. cells say, oh, that looks like a little fatty treat, and they take up this little fat ball. And when they take up the little fat ball and digest the little fat that's in it, the mRNA then gets into the cell. The mRNA then works in your ribosomes to make proteins. The body says, well, this is a nice protein, but it's not anything we need, so let's put it on the outside of the cell. It puts it on the outside of the cell, and then the immune system says, wait, this is a foreign protein we've never seen before. It makes an antibody, and now you have an antibody to this protein. It's an incredibly complicated process, but really does seem to work. I think the efficacy on this is far more than any of us could have hoped. If this had been 50% effective, I think we all would have been thrilled. At 90% effective, this is great. So it's not two witches in a cauldron. Some of these are made in the United States. Some of these are made in Europe. Now, I will tell you, countries all around the world are making different kind of vaccines, some of which may be great. So, for example, India took a different approach. What they found is they tried to find the code for this and inject it into yeast so that yeast would make this protein. They then collect all this protein, purify the protein, put it in a syringe, give it to you. There would be this protein circulating in your bloodstream. Your body would note that this was a foreign protein and make antibodies. That's an approach that we've used many times before and could work well. They've had a little bit of time growing enough protein to make this work. So Jan says, do you need volunteer nurses to help administer vaccines? We're going to need a bunch of volunteers, and as we said before, administering the vaccine is going to be one thing, but also setting these things up where people can drive in and drive safely, collect all the information that you need to do, watch people after they're done to be sure they're not going to have a reaction. So we think we're going to need to get a lot of people vaccinated. So to give you the numbers, there's 110,000 people in Douglas County. To get to herd immunity, you need 60 to 70% of the population to be immune, which means we need 70 to 80,000 people immune. Since the vaccine is only 90% effective, that means we're going to need 75 to 85,000 people vaccinated. We know that everybody's going to need 2 doses, so we're saying 160,000 doses we need to give. And there's 160 work days between now and the 4th of July. So we need to give 1,000 doses every day. Now, we're really good at this. When we did our flu vaccine, we were really good at it. We gave 200 doses in a day of flu vaccine. We could have given more if there were more people there, but we gave 200 doses in a day. We're going to have to quintuple that and do it every day between now and the 4th of July. So this has really got to be a moonshot. This has got to be an effort where we all come together. We're going to use a lot of volunteers. We're probably going to use a lot of different spaces. We're going to use a lot of different people to get it together. It is not going to be perfect, but nothing this big ever is. And the deal is we just want it to be really good, and we'll get there. So Jan, yes, we're going to have a volunteer coordinator soon, and this volunteer coordinator is going to coordinate volunteers to both give vaccines. People say, well, I don't know how to give vaccines, or I'm a little nervous giving a vaccine. Great. We're going to need people to do other things too, like collect data and bake cookies and all those things that you do to make one of these things work. So 2 questions. If you've had COVID and recovered, should you still wear a mask? Or if you've had the vaccine and are immune, should you still wear a mask? And the answer is yes. And the reason is that neither having the disease nor getting the vaccine is 100%. So there's still maybe a 10% chance that you would still get the disease and still be infectious. So for that 10%, that would be great. The second is, it is going to be really hard to parse out if some people need to wear a mask and some people don't. So until everybody has a low enough rate of disease, until we all have a low enough rate of disease and a high enough rate of immunity, we're going to ask people to do the same public health things we've done before with social distancing, wearing a mask, avoiding big groups. All right, let me go through a few other things here. So one of the things I hear the most about in terms of misinformation is about deaths. And see if I can find it for you here. And so I pulled together the big myths that I hear on an everyday basis, and let's go through those. So the first false narrative I hear is that, those deaths that they attribute to COVID are really deaths that would have otherwise occurred and being falsely attributed to COVID. Like the person gets run over by a car and they say it's COVID. So people point to the CDC study that showed on many of the death certificates of people with COVID, they had other comorbidities, and that only 6% of the people had COVID as the only diagnosis. Well, let me reassure you that the deaths from COVID are recorded just like we record any other death. There's nothing special about COVID. So let's take other diseases. So most deaths start with a disease. You then get some complication or progression of the disease, and then they finally result in some kind of mechanism of death. For example, somebody might get pancreatic cancer like Alex Trebek. They then develop a secondary complication like a bowel obstruction due to the cancer. So the cancer has spread around your small intestine and makes it impossible for food to go through. And then they're unable to eat or drink. And then they finally die of dehydration. Well, this is not a dehydration death. This is not a bowel obstruction death. This is a death with pancreatic cancer, resulting in a bowel obstruction, resulting in death due to dehydration. And similarly with COVID, a person gets diagnosed with COVID. They then develop a pneumonia secondary to the COVID. And the pneumonia progresses to respiratory distress and respiratory failure. They go to the hospital, they're given oxygen, they go to the ICU, they get intubated. But despite the best efforts, they die. So then if I was going to fill out that death certificate, this is how I would do it. Look to see if there are other complications. And yes, because of the COVID, they also wound up with kidney failure, or they wound up with a clot in their leg. What I would say is this was COVID resulting in respiratory distress, complicated by kidney failure, ending with cardiorespiratory arrest. So the way we do COVID deaths, the way we do all the other deaths is exactly the same. There's nothing new. There's nothing different. There's no special rules for COVID. In fact, what I would say is that CDC study that had COVID as the only thing on the death certificate was likely done quickly. Maybe you had 30 COVID deaths that day, and you just wrote COVID, COVID, COVID on all of those. Those are the ones that were likely incomplete. The other 94% that had other things, those were likely the ones that were done correctly. So the second thing is people tell me stories of people who had clearly a different cause of death that had been attributed to COVID. I know this guy who got run over by a train and they called it COVID. So I'm not saying it's never happened. I've never seen it. And for 4 months now, I have offered a crisp $50 bill to anyone who can show me that case in Oregon. As a health officer, I can look at all the death certificates. And so if there's anyone in Oregon who knows of any one case, let me know and you'll get your $50. But after 4 months of talking about this, I haven't found any cases and nobody's taken me up on the offer. So I conclude if these things happen, and maybe one place somewhere in the world this did happen, they either don't happen or if they do, they're incredibly rare. So really the deaths from COVID are from COVID. So the next thing I hear is that, well, we shouldn't really worry about COVID because it really only affects old people, and they were going to die anyway with or without COVID. But that is clearly not true. I mean, it is true that most of the deaths from COVID are in people who are 60 and above. I'm over 60. And the rate for death for young people is quite low. Well, thank goodness for that. I mean, I don't think anybody's hoping that the disease would be more deadly in young people. It's not very deadly in young people. It gets more deadly as we get older and older and older. So that people 80 and above who get the disease, about 15% of them die. Well, but this is true for many other causes of death. So I looked through the death things today. The leading causes of death in the U.S., heart disease, cancer, COPD, stroke, Alzheimer's, all of those predominantly affect the elderly. I mean, I don't have many of my pediatric patients dying of any of those things, right? In fact, I don't think I've had any in the last 5 years die of any of those diseases. There are some diseases that don't primarily affect the elderly. They are diseases of the newborn, not shockingly, accidents, which go across the age spectrum, homicides, and suicides, all of which go across the age spectrum, and war deaths, which are concentrated in people in their teens, 20s, and 30s. So yes, older people do die of COVID more than younger people, but that really is for all of the diseases. And we don't say, we don't care about cancer, it's just old people. Or, we don't care about stroke because it's just old people. We should care about all of the diseases and recognize that the death profile from this is really not all that different from many of the other leading causes of death that we care a lot about. So the next thing I hear is that people who die from COVID, they have underlying conditions. That's true. But by the time we hit the age of 60, 85% of people have underlying conditions such as obesity, high blood pressure, diabetes, they had a cancer that they beat. And so it's not shocking that most of the people who die will have underlying conditions because they had that. But is anyone trying to say that that person who beat cancer, and now they have this underlying condition, somehow doesn't deserve to live because they have that underlying condition? That to me is really objectionable. And last, I hear that, people die every day and the number of deaths from COVID is really insignificant. Any day you have a 99.99% chance of not dying of COVID. Well, I will tell you, any day you have a 99.99% chance of not dying of anything. Because, most of us are going to live, hopefully, 70, 80, or 90 years. So let me get the story. So let's take before the pandemic. Every day in the U.S., about 7,500 people died every day. Of those 7,500, about 1,800 died of heart disease, about 1,600 died of cancer, about 500 died from accidents, about 500 died from COPD, about 500 from stroke, and about 400 from Alzheimer's. Okay, so that's where it was. But over the last week, an average of 2,000 people have died every day from COVID. And on Wednesday and Thursday of this week, over 3,000 people died. 3,000 deaths is a lot of deaths. That's the number of deaths from 9/11. It's more than the deaths from Pearl Harbor. Thus, in December of 2020, COVID is going to be the leading cause of death, far exceeding the number of deaths from heart disease, far exceeding the number of deaths from cancer, far exceeding the number of deaths from stroke, Alzheimer's, and COPD combined. And the number of total deaths is up. So it's not like you say, these COVID deaths are people that are going to die the next day anyway of cancer or one of those things. That's not true. The total number of deaths is up. About 350,000 excess deaths between March and November of this year. And the places with more COVID have more excess deaths. Oregon has about 1,800 excess deaths over a typical year. So somebody sent me something the other day that Oregon has seen a decrease in their death rate. We're 1,800 deaths up. Now, that's not a huge number, right? We typically have about 50,000 births a year. So that's not a tremendous number because Oregon has had a low rate of disease. But if you look at a place like North Dakota or South Dakota, they're having 50% more deaths than they otherwise would have. So COVID is a very significant cause of death and is increasing overall mortality. And unless I have my numbers totally wrong, life expectancy in 2020 is going to decline. So that the amount people live is actually going to go down. For years and years and years, we saw an increase in life expectancy. Over the last 5 years, the number have been kind of flattened, but I think this year we'll see a definitive decline. So this is serious. Now, you may not see it very much in Douglas County because, we're not that, our hospital only has 14 people in it. We have a couple of deaths a week. But if we were in another place in one of these other counties that the hospitals are absolutely full, they're sending people out, and they're having a dozen deaths in a week, this is really serious. Okay. Let me see if I have more questions here. Computer is being slow. Okay. So is some organization planning to coordinate all of the volunteers for vaccine distribution? So there are three streams by which vaccine is going to be delivered. The first one is vaccines for long-term care facilities is going to be distributed by the pharmacy partnership between HHS Walgreens, CVS, and a couple other pharmacies that are going to live it to the nursing homes. They are not seeking volunteers. The second group is the hospital. They're going to get a bunch of vaccine. They're going to vaccinate their hospital staff. I talked with Dr. Gray today, and they're going to do this internally, where they're going to use nurses internally. They obviously have a lot of nurses and a lot of buildings, so they're going to do this internally. The third is when we start doing it now for people in the community, we will be looking for volunteers. And so DPHN, or Douglas Public Health Network, will likely coordinate those vaccine volunteer events. So our hospitalized folks who look like they won't recover being sent home to die with hospice and their loved ones, Kat asks. Well, Oregon is different from other states. Oregon has one of the lowest in-hospital death rates. I think in Oregon, a lot of people, regardless of the disease, cancer, heart disease, COPD, decide that they don't want to die in the hospital in a medical setting and would rather die at home with comfort measures and with family. And so Oregon has a strong history of the use of hospice, and I think it's one of the most great things about Oregon. Similarly, this is happening with COVID. We have a number of people who have COVID. They're really quite ill. They're on a lot of oxygen, and they're faced with being sedated, have a tube fitted, be in the ICU, where they can have friends and family visit, or they can go home, get some comfort care at home, and die at home. Interestingly, most times by the times that people are in the hospital, in the ICU, they're no longer contagious, so many of them can go home. Some still are contagious, need to go home with preventive care, but for most other people, they can go home, and they can be at home with their family. And so a lot of people do that. So about a third of our deaths have been at home, and people who have been on comfort care. So do you have an average length of stay for hospitalized and the percentage of them that end up in the ICU? Dale Ann asks, and I'll have Vanessa work on that. In the past, when we looked at our average length of stay was 6 days. And in the past, when we looked at the number that wound up in the ICU was about a third. So when people get hospitalized, about a third are on the medical floor, about a third in the PCU, about a third in the ICU. Now, people switch between, right? So they start out really sick in the ICU, they get better, they go to the PCU, and then they go to the floor. And the other way around, people start off not that sick and get sicker and wind up in the ICU. But when we look at our daily hospital things, it's about a third, and a third. So Alan says, what is COVID compared to the flu? Well, COVID and the flu are somewhat similar. They're both RNA respiratory viruses. They both probably came from animals to humans, and they kill a lot of people. Okay, so let's get the difference between the two. They're not in the same family, though, so they're different viruses. Flu viruses are from influenza. These are beta coronaviruses. This disease is many times more contagious and many times more deadly than the flu. So if you compare the deaths on this, so remember I told you about how we do the deaths with COVID and how we do the deaths with pancreatic cancer. If you do the flu deaths that way, the number of flu deaths is very low, right? The number of people who actually get diagnosed with the flu and then die within a certain period of time is actually pretty low. But we recognize there's a lot of excess mortality in the wintertime, and so those deaths are attributed, respiratory deaths are attributed to flu and other pneumonia-like illnesses. But if you compare them apples to apples, COVID is 20 times worse than the flu. So 20 times worse than the flu. More contagious and more deadly, and a lot of long-term complications. There are not a lot of people who have long-term complications of flu. You get it, you feel crummy for a week or two, but you get back to normal. What we're seeing with this is a lot of people with very terrible long-term side effects, chest pain, shortness of breath, this funny myocarditis thing that you have, a change in smell and taste. And so it's much worse than the flu. So anybody who wants to compare this to the flu, yeah, they're kind of like the same, but this one is so much worse. If this was the flu, we treat it like the flu. But I tell you, I worked in the hospital during the 2009 flu pandemic, 4 or 5 people in the hospital during the worst of it, 2 deaths. I mean, now those 2 deaths were tragic deaths. Actually, I knew both of the people who died. Tragic, tragic deaths. But the volume of this and the severity of this was so much less than this. So our statistician says about half on the med floor and about half in the ICU and PCU. Between the ICU and the PCU together, so the intensive care unit and the progressive care unit, both high-level units, about 2/3 of the people, between half and 2/3 of the people in those units. So again, about a third, and a third, which means that they're all not in the ICU. But in Oregon, if you look at our number of hospitalizations, it's high, a little over 600 a day. And, if it stays at 600, we'll be able to make it. But if it goes to 800 or 900, we're going to really have to, the hospitals will really, 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 really get tight. Okay, a couple other things we want to talk about. Excellent article in the journal Lancet, which is a British journal, that looked at schools in England. And so they looked at schools over time, a lot of kids, about over 1 million kids that they looked at, and they looked to see what happened. And their experience is very similar to the experience that we had here. That most times when there are cases in schools, they're onesie-twosies. Somebody gets exposed at home, is in school, and is positive, or a teacher gets it somewhere, comes in, and they get it. And that very rarely, in our experience, almost never, do people move it to each other. The most common, actually, was teachers giving it to another teacher, probably in the break room. Students giving it to other students, really uncommon. Students giving it to teachers, quite uncommon. Teachers giving to students, quite uncommon. So what this tells us is that spread in schools is pretty uncommon. Not that it never happens, but it's pretty uncommon. And when you realize that the alternative is being at home, where you may not be taking, or at home or at daycare, where you may not be taking those precautions, it actually may be that school is the safest place to be. So, I see people come in the office and they're bringing 5 kids around and they say, "Oh, are these all yours?" "No, I'm babysitting for all the kids in the neighborhood." Well, they're all together and not wearing masks. And so that may be a far high riskier situation than actually being in school. New York City is really stressed about having kids back in school. And so they've really stressed being back in school. And I think that is a good thing. A couple of things we saw, some new data on long haulers. Again, these are people who had the disease and then later on continue to have symptoms. There's a lot of people out there who weeks, months, and now even from the beginning of the pandemic still don't feel great. So that is a big worry. Okay. Yeah, so what's the opinion on antibodies, the ability of COVID antibodies to keep one safe from reinfection? Well, statistically, it looks pretty good. So if you look at people early on who were infected, most people have not gotten infected again. There are clearly some cases where people have been infected, got better, and got infected again. So it's not perfect, but it's pretty darn good. And in fact, from this study, it really looked like it's about 90% good. And I would say, looking at the people who say I got it again, it's probably 90% good. So antibodies are 90% good, which is pretty great. Now, antibodies in some diseases are nearly 100%, like hepatitis B and measles is nearly 100% good. But 90% good, I'll take it. And so when the vaccine comes out, as soon as I'm eligible to get it, line me up and I'll get it. Now, do you worry about side effects? Yeah, I always worry about side effects. But I think in this case, the possibility to get this disease down enough so we can have some resemblance of normal life come next summer is far and away worth it. Now, the way I look at this vaccine may be different from others. And I think one of the things I've noted during this pandemic is that people look at the same data and can interpret their risk differently. So some people do all kinds of risky things. They jump out of planes and ride motorcycles and whatever else. And their view of that risk is very different from mine. Don't ever make me jump out of an airplane or ride a motorcycle. And so we see risk differently. And then people also see the risk of the vaccine differently, right? Like, oh, I remember one person I heard about one time that got a bad reaction to a vaccine. I don't think I want to do it. and then other people view this differently. So one of the things is people view risk differently. And I think there's been a lot of criticism of people if they view risk differently than you do. My sense is everybody's going to view risk differently, given maybe exactly the same circumstances, like going to take a 60-mile motorcycle ride to Eugene. What is the risk? It's low, right? It's probably only 1 in 10,000 or less. But some people may think that risk of 1 in 10,000 is not worth it when they can drive a perfectly good car. And so I think during this, we have to be a little kind and we have to be graceful to people who might have a different view of risk tolerance. Similarly, I would ask the same from others. So I wouldn't want others to criticize me like, oh, you're just being a sheep here following up on getting that vaccine. Can't you think for yourself? Please don't tell me that. I recognize that you may not want to get the vaccine, and I'm not going to force you to get the vaccine. But what I'm going to tell you is we really need to be kind to each other about that. So Beverly says about the allergies that they've seen in England when they first started giving this vaccine. There were 2 cases where people who previously had severe allergies to things when they got the vaccine had a reaction, and they had EpiPens with them, and they gave themselves the EpiPens, and they recovered. We don't know about that. We don't know a lot about that. I have not seen the FDA stuff about that. So they may decide that if you've had a severe reaction, you shouldn't get it, or if you've had a severe reaction, you should only do it in a place with full resuscitation equipment available. The other question is about pregnant women or nursing moms approved to get the vaccine. Again, the FDA hasn't ruled on that. They said they were going to do it tonight, and I'll take a look when it comes out whether pregnant women, nursing moms are on the list to get it. There's always a problem with things in pregnancy. It is really, 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 really hard to test in pregnancy, right? So you might say to me, Bob, would you be part of an investigational study to try out this medicine to see if there are side effects? I say, well, sure, I'm an old guy. Sure, I'll do it. And I would do that kind of thing. But if you said, your wife is pregnant with your kid, we're going to do this, we don't know what kind of side effects it is it okay if we enroll them? I say, hell no. And that's why it's really, really, really hard to do studies on pregnant women and nursing moms. Now, here's the good news. The good news is everybody doesn't have to get the vaccine, right? We do not need to have 100% of the people get the vaccine to get rid of this. We need about 70 or 80% of people to get the vaccine to get rid of this. And so if there are a few people we can't give the vaccine to, pregnant moms, whatever, that's okay, because there's still plenty of people who are not pregnant or nursing who could go ahead and get the vaccine, and moms who are pregnant or nursing won't be pregnant or nursing forever, and when they stop being pregnant or nursing, they could go ahead and get the vaccine. So this is a question, for example, with measles vaccine. So I have 2 kids who've had heart transplants. And these 2 kids I take care of with heart transplants are never supposed to get another live virus because their immune system is being suppressed by these drugs because they have had heart transplants. And so they can't get a measles, mumps, rubella vaccine. And people say, well, isn't that dangerous? Well, it's only dangerous if the other 19 kids in the class don't get their measles vaccine. If the other 19 kids in the class got the measles vaccine, they really don't need to get it. And that's why we want to have this high rate of vaccination for something like measles for those rare kids who can't get it. In this case, the rate of immunity we have to have is not nearly as high as for measles. So the story is, we'll see what the FDA says about pregnant women and nursing moms. But if they say, don't give it to them yet, I'm not too worried about that because, again, there's plenty of the rest of us who are not pregnant or nursing who could get this vaccine. All right, it's 5 o'clock. We need to go at 5, so thank you all. We'll do this again on Tuesday next. If you have questions between now and then, please put them at our email address at facebookquestions@douglaspublichealthnetwork.org. And if you have comments, you can put them in the comments section here. I usually review these at night and add my own comments to them. Again, Dr. Bob Dannenhoffer, Public Health Officer in Douglas County. Thank you all. Bye-bye.